Hello everyone, my name is Luis Augusto Dellan. I'm a physician from University Hospital's Cleveland Medical Center, and on behalf of the structural heart team led by Dr. Guilherme Atizani, I would like to present a clinical case of intravascular lithotripsy with Shockwave in a subocclusive femoral access adjuvant to the transcatheter aortic valve replacement, conquering new horizons. I have no conflicts of interest with this presentation. So in this case, we present a male 82-year-old patient with heart failure, New York Heart Association class 2 symptoms. He had a severe aortic stenosis with an aortic valve area of 0.54 centimeters square, with a mean gradient of 36 and a peak gradient of 51, and an ejection fraction of 60%. He had COPD, ex-smoker, atrial fibrillation on apixaban. He had a stroke in 2013, diabetes, hypertension, osteoarthritis, a total right hip arthroplasty, and CAD with previous PCI with a DS to the obtuse marginal. He also had a chronic artery insufficiency due to severe bilateral iliac stenosis that would contraindicate his procedure in a regular basis. So the EKG showing atrial fibrillation. So as we said, this is the angiogram showing a very narrow stenosis of the bifurcation of the iliacs that would normally contraindicate the procedure through the femoral axis. So we decided to perform this lithotripsy to allow an adequate access through the iliacs and allow us to perform the procedure in a regular way. So this is the CT angiogram showing the measurements of the valve. So we can see like 87.5 millimeters perimeter with left coronary artery height of 20, right coronary artery height of 13, with an LVOT of 27/18, with a Valsalva sinus of 35/34/34, and an STJ of 31/30. So we decided to implant an Evolut valve at 34 millimeters. In this figure, you can see on the left the iliac angiography showing severe stenosis of the iliac bifurcation. So we opted to use the left femoral as the principal access to put all the devices and all to perform all the procedures. So we performed the Shockwave procedure in the left femoral artery to the iliac bifurcation, so that we could put all the material and so that the valve could be placed through the left femoral artery. So this is the positioning of the balloon for the IVL treatment with Shockwave, as you can see in the center image figure. So to the left, you can see the positioning of the balloon, and to the right, you can see the deployment of the balloon with the initial shock waves being provided. So here you can see the IVL treatment by Shockwave. So there were performed 4 treatment cycles with 20 sonic shocks in each treatment. Here you can see on the left the aortography, baseline aortography that guided the procedure, and to the right you can see the BAV procedure, the pre-dilation, with a true dilation balloon 18/45. So here in the left image you can see the positioning of the Medtronic Evolut R 34 millimeters valve, and the right image you can see the very shallow positioning with the initial deployment of the Evolut R 34 millimeters valve. Here to the left, you can see the deployment of the valve in a regular way, and to the right, you can see the angiogram showing a good position. So the valve was deployed in this position without any complications, with a good final result. This is the final result of the iliac bifurcation to the left femoral artery, showing a great final result for the bifurcation without any kind of complication. For the clinical outcomes, it was a successful final result with the Evolut R34. No paravalvular leak at the end, the final gradient of 6, and we used the minimalist approach with local anesthesia. So the patient walked in the same day of the procedure and was discharged home next day before noon without any kind of complications. So as a conclusion, the procedure that once would be contraindicated now is available, safe, and feasible. So even for the severe stenosis of the iliac bifurcation, now there is this option, this alternative option, to treat it with a shockwave and to allow a good pathway so that the valve can go up, and our regular access, the femoral access, can be used even for severe stenosis of the iliacs. Thank you very much.